but the topic was written about the steroid the steroid hormones and the skin. And you see here that I'm going to, so how's the pointer working? So I will, okay, so how the pointer is working? But I point here, or I point on the screen? Yeah, okay, sorry. So I will mainly focus on two things, on the Addison disease and on Cushing disease. I will just put one or two slides on polycystic ovaries, and of course, it's not in this topic to go into the other hormonal consequence on the skin. So we'll begin quickly, and we go on cortisol deficiency, describe and call Addison diseases. So I put for the two diseases a left column and a right column. And on the left column, I put the general signs that can be present. And you know that in Addison, there is a big fatigue, asthenia, malaise, anemia, anorexia, digestive sign, and all that can develop very progressively. And on the first part and the upper part of the left column here are the clinical general sign. Here are the biological sign with a very classical decrease in the sodium and the increase in the potassium, as well as all the other, but I think that you know it very well. And I would say that mainly there is one sign, only one sign that you know, which is the hyperpigmentation that occurs progressively in white or in pigmented people that are going to be more intense in the flexural area, the site of friction, the recent scar, and including the mucous membrane. And there are no other skin signs that are related to the Addison. And the one that I wrote below here are not the sign of the disorder, but they are the skin signs of other autoimmune diseases that are associated with it. So what is the mechanism of the melanoderma, as you know, and I will show them in the next slide. It is the stimulation of the pigmentation because of the fact that you have a loss of a negative feedback, and the causes and the mechanism of the adrenal insufficiency are mainly either peripheral and autoimmune or central. So you see here what's happened is that on the normal way, you have here the cortisol that is secreted by the adrenal gland that is acting through a negative feedback on the HPA axis. And if you have a negativity of the negative feedback, therefore you are going to lose your brake here, and then therefore you are going to have an increase in these hormones that are secreted, including alpha melanocyte stimulating hormone, and this is going to lead to the hyperpigmentation that you know. And these are examples that I took from papers because I tried to see in our library we had some, but I was too short to really find some. So it can be, of course, discrete or intense. And what you see here is on the face. Here you see the tongue present. Here you see these increases in the flexural areas. All these are fully non-specific, but this is interest and the difficulty of dermatology is that we have, of course, much more diseases than we have of clinical signs. So there is barely no specific clinical signs, and these are from children. And you see again here example of the mucous membrane under the face. You see that here the signs are rather discrete. And the question here is that I showed you that this melanoderma was linked to a reaction of the hypothalamus and the pineal gland to the low production of cortisol by the adrenal glands. But what are the signs if the disease is not in the adrenal glands, but they are rather at the upper floor and they are present in the hypothalamus or on the pineal gland, where therefore there are no skin signs? I just put in the second sentence here something that is potentially described, but barely, if there are a central hypocorticism, you will have no signs. So therefore, this is easy to go. And you see we are quick in describing these diseases, and therefore I'm going to go into the reverse disease. And again, in the left column, I put you all which are not on the skin side, but nevertheless very important for we as clinicians, because of course we are not dealing only with looking at the superficie of the body, but we are also clinicians who are hearing our patients and seeing what they are. So you see that you have really here a long list, and this shows you how much the cortisol is interacting with the whole organism of the body. It's like the thyroid disorder, where you have also a diversity of the sign. And here, in contrast with the previous disease in which you had only melanoderma when the hypocorticism was peripheral, here you have something much more. So you have this facial plethora. I will show you at the end a picture. You have a full modification of the skin, and I will show you some of this on the ultrastructure, on the histology, but this is going to give you a thin skin with what has been called sometimes dermato-endocrinology, with purpura, with striae, with acne, and all of these are described here. I will show you a little bit later on the incidence of here. So I told you that before, for the adrenal insufficiency, the main cause were peripheral, and you have less causes for the upper floor, for the hypocorticism, except, I have to say, except for Addison, the fact that since we, as dermatologists in Europe, we still treat our melanoma patients with immunotherapy, we now see a lot of patients who have hypocorticism that are due to hypophysitis, that is immune-mediated by the anti-PD-1 or the anti-CTLA-4 antibody. Sorry, I forgot this. So here, what are the causes of hypercorticism? Where we have two causes. You have the endogenous one, and the endogenous one are either linked to tumors, and the tumors may be either low or high, let us say, or you may have ectopic production by extra adrenal and extra hypophyseal gland, or here you have an increase in the ACTH production that is not linked to a tumor but to an excess secretion of the gland. And this is for the endogenous, means that the cortisol comes from the own patient's self-gland. And this is going to give you all the clinical signs. But of course, and you know it better than me, when you give oral and much rarely local, but it occurs also for local corticoids, so either orally treatment or applying on large surface on the areas of the body, where you are able, of course, to have a Cushing's iatrogenic disorders. And this is a nice paper that has been published recently in Nature Metabolism from the group of Guido Kremer that shows very well the role of this acyl coenzyme A binding protein in really the modification at each peripheral tissue under the dependence of the corticoid hyperproduction. I chose this paper. Why? Because it was a time when it was, I would say, easy and nice to do papers with 1 or 2 figures. And for instance, this paper is signed by Albert Kligman. So I see Rolf in the first floor, who maybe with me is a unique one to remember the personality of Albert Kligman, who has described the trio of Kligman, and he was really, I would say, a giant of dermatology. And you see how the figures were in black and white. And in this paper, I think that everything is in this result. There is maybe one other figure. And just see, you have just to see here the effect of clobetasol. They have taken human volunteers, they have put clobetasol under occlusion, and they have found number of histopathological changes. I will go quickly because you have an epidermal atrophy, you have a dermal atrophy, you have not so much decrease in the fibroblast. I was rather astonished when I saw that there was not so much decrease in the fibroblast. You have collagen bundles that are in full different direction. You have a lot of free spaces between these collagen dermal fibers. So you see all this disorganization of the skin. I wanted to include this. This is another paper of the good period also, where it was easy. And this is a radioimmunoassay, a technique that nobody of you, except also maybe Ralph and me, knows. So this is a radioimmunoassay where you see also it was human volunteers treated with topical corticoids. So you see when you give topical corticoids, a big change, 4 weeks 4 weeks of betamethasone, and you have a decrease in the collagen 1 protein. In the collagen, this is a 3 protein, you see the decrease, less than 10% of the amount left, and here you see the mRNA. Again, you have a real loss of the collagen in your dermis, and this explains you why the skin is so much changing when it's exposed to corticoid cream. And this leads me back to the clinic, and I show you something is when you take a series where you have a systematical cutaneous examination by dermatologists of the skin of patients who have a Cushing disease, you have up to 90% of the patients who have at least one clinical sign. So really it's a disease where you have an expressivity, an expression, a phenotype of the skin under the over-corticoid treatment, either locally or either systemically. When you don't have a systematic clinical examination, you have nevertheless very high percentage of the figure. You see 70% of some of the clinical signs that you have to see here. So I wrote in the title of this slide, more than atrophy and striae, because you have acne, you have hirsutism, you see the incidence, you have rosacea, you have what is called dermatoporosis, you have fungal skin infections. There is a big literature on the fact that these patients have very frequently fungal infection, and you have also like quarter of the patient who also have acanthosis nigricans changes in the fold. So these are patients of mine, and you know all these signs. So there is nothing specifically, but I took them for my own patients, and you know here that you have purpura and skin atrophy, you have typical rosacea, you have this purplish striae that are well described by everybody. And I took this from a recent New England journal, so you can do also maybe easily the PubMed on your name in the New England if you have a nice picture. I don't know if it's important for the academy to have this, but it's always nice. And this is a caliper. So the caliper allows you of a lot of things. For instance, in mice, you can measure the thickness of the ear if you have an inflammation. But here it's to have a quantitative evaluation of the thickness of the skin, the equivalent of the Rodnan signs for scleroderma. And here under treatment, it goes from 1.8 millimeter before treatment to 1.2 millimeter. It's an elegant way to say something that we all know clinically, but I chose to show it to you, and this is what is called pletora. Pletora, we call it Cushingoid syndrome, with this edema and the remodification of the fat tissue and the loss of the muscular tissue. And it's a clinical sign. This paper is from a Turkish group, and what you see here is that you have 4 signs that I put in blue, and these 4 signs here are the ones that are differentially present on the incidence between exogenous and endogenous corticoids. What means exogenous? Means that you have, you see it here, you have much more striae, you have much more hypertrichosis, you have much more hyperpigmentation, let's say more, and much more fungal infections if you are putting corticoids than if you are having an endogenous secretion of corticoids. Remember this because you know that we treat bullous pemphigoid with high dose of topical treatment, and we know really that our aged BP patients that we treat with clobetasol are really have a skin insufficiency in view of the amount that we have. When you see patients with skin sign, you have to do the diagnosis. Mainly the diagnosis is done on the cortisol at 8 o'clock in the morning, as well as the cortisol in the bladder, in the urine, sorry. But if you want to know really the algorithm of the diagnosis when it's difficult, this one is a Lancet paper, and of course I won't go into detail, but it can be difficult because it needs dynamic tests. Of course, I will not go on into the detail. I will give you a quick overview on a way to protect the adverse drug reaction to glucocorticoid. So you see here that you have cortisone that is going to go into the cytosol or to be shuttled by a receptor. And you see here that when it goes into the cytoplasm, it could bind either to the GR or it could bind to a closed molecule that is the mineralocorticoreceptor. And you have 2 types of organs. A type of organ where this enzyme is low, And it's the case of the skin. And when this 11-beta dehydrogenase is low, such as the skin, the fate of the cortisone is either to go to the MR, either if you have a low HSD2, it's able to bind to the MR, such as the skin. So you have two receptors that can be implicated. And I'm going to show you very quickly a type of way that can protect. So this is a paper of our group where Ventuan and Guyenne, what he did, this is the back of a mice, you shave the mice, and we do wound healing. And these are the mice that have received clobetasol. And you see here that the wound doesn't heal as compared to the control application. But if you apply clobetasol with carrenoate, which is a mineralocorticoid receptor inhibitor, where you are much improving the wounding, and this is both true on the planimetry, but also on the skin section where you see really a complete section. This was mice, but this is human, and what you see here is what we call a human skin explant, and you see that you have a band of neoepidermis that you can see either by, that you can see here either by histology, either by K14 labeling. And what you can see here is when you are under the clobetasol, you have a very small neoepidermis. But when you are rescuing, I call it a rescue, because you see here that you have a much better migration and a surrogate of healing when you co-treat with corticoid and with this mineralocorticoid receptor. And this is a human trial that we also did with Eve Mobeck at that time present in Bichat. And what you see here is, again, not the wound healing, but the atrophy of the skin. So you can see here that you have a thinning of the skin under the clobetasol, and you see here that you are rescuing it with all the parameters present here. And even the wound healing, I will not go into detail, but this is also the same paper. And the last slide was here, in the wound healing, where, so these are volunteers had biopsy punches, and if you go at, so these are the figures, and if you see here, for instance, that you, so it's not completely as in the mice so much different, but it's much better therefore, because you see really that you have an improvement of the wound healing when you were putting a mineralocorticoid receptor, and this was the editorial that was accompanying our paper. I will just say one word of the Carney complex, because it can be both a case of hypercorticism, and since in the genodermatosis you have other signs, and here you see these lentigines that are typical of the Carney complex, and here you see myxoma. So this is, of course, is a rare genetic disorder that is due on mutation, and I think we won't have time to go into this disorder, which is a polycystic ovaries, but just keep in your mind this, that is a nice paper, that in the polycystic ovary syndrome, which are not corticoids, but of course it's androgen, you have three important signs and one that is less related. The three important signs are acne, hirsutism, and acanthosis nigricans. The fourth sign is much less a reliable marker of polycystic ovary syndrome. The three early ones are well markers of real polycystic ovary syndrome. And here are the signs. You see here the hirsutism. Here you can see an acanthosis nigricans. All these also are patients of mine. And you see here acne with scars and inflammation. And this gives me on time to conclude that you have really a large number of interaction between skin and the steroid. And these are going to affect large area of the body of the mucosa. I wanted to tell you that there are really a very large domain now of interaction of the stress and the skin through the HPA axis, and there was really last month an impressive paper of the group of Nicolas Gaudenzio in Toulouse, where they have stressed females during pregnancy, and through the cortisol secretion, the offsprings had eczema after delivery. So really, the axis of steroid and the skin is a very interesting one, and the future can be eventually, potentially, to separate the anti-inflammatory activity of glucocorticoids and the skin. And I think that our instruction that we will keep the question at the last. So now I'm happy to introduce you my my future speaker and co-chair. So I'm happy to introduce you Professor Shyam Verma from Mandura in India. He's very well known famously in the world and have been present in the board of a lot of organizations in India and Europe. And it's a pleasure and an honor to hear you. And you are going to talk of something close also, which is facial acanthosis nigricans. Thank you for attention.
I'm Shyam Verma, and I'm going to speak on facial acanthosis nigricans. How many of you see facial acanthosis nigricans? No? Few, yeah. Of course, you would be seeing quite a lot. So I declare no conflict of interest, and I'm going to introduce this because this, with all the increasing migration, you'll be seeing a lot of this. A FAN, that is facial acanthosis nigricans, accounts for approximately 7.5% of the facial melanosis, predominantly affects the dark skin types like the South Asians, Hispanics, Africans who are, there is a rider here, they are usually obese or they are overweight. And there is, I would say that it is inadequately mentioned in international literature, including the major textbooks. And it lacks a precise definition of its clinical and histopathological features, probably because facial acanthosis nigricans is something that people do not want to get biopsied, because, and for obvious reasons. There are these two papers here written by us, and whoever is interested, do take a picture of this, because these will give you a lot of ideas on what this disease is all about. This is what facial acanthosis nigricans looks like. Now, probably those of you who have seen it but have not really associated it with a name, you'll know. Brown to black macular pigmentation with blurred, ill-defined margins, and it's not just the color, but it's also the texture of the skin which is affected. And it has been variously labeled with lots of names like metabolic melanosis, metabolic melasma, maturational pigmentation, which is a very American term, and often misdiagnosed. We'll talk about the misdiagnosis also. It has multifactorial pathogenesis. The epidermal keratinocytes and dermal fibroblasts, they proliferate because of hyperinsulinemia, which is associated with the facial acanthosis nigricans, and that causes high level of insulin-like growth factors 1, and this causes the decreased IGF-BP, which is insulin-like growth factor, what is it? The binding proteins. So these binding proteins are decreased in people who are obese and who are pigmented, and then it leads to a free floating insulin-like growth factor 1, and that is the one which is responsible for the tissue growth of fibrocytes as well as the keratinocytes. And there is the other things like growth hormone elevation, which is found. There are increased number of melanocytes also, and there is melanin increase in already pigmented skin, so this can become worse. So does sun exposure, so does friction. We'll talk about that later. There are some like medications which can also cause acanthosis nigricans. Now, how they're usually seen in the 3rd to 5th decades, it's predominantly males with truncal obesity who get this. There is I'm not going to read this out, but I'm going to show you a lot of pictures which will make things very clear. I hope you don't mind, because that will give you a very good visual impression. Look at this. Now, this is a horizontal band on the forehead. This is typical of FAN. Then there is also a merging of the horizontal pigmentation and a C-shaped band, which is like a C. And my colleague from Poland, I would please request you not to record these, the lecture in the second row from the iPad. That's not nice because you asked for permission and we said no. Then, so this is another band merging and with the C. Then you have varying colors. So you have mild acanthosis nigricans, like you see at the bottom there. Then you have a slightly increased one, and then you see the real dark acanthosis nigricans of the face with altered texture of the skin. So you can get mild roughness of the skin, which you see in this man on the left, to look at this man on the right-hand side who has absolute textural changes with the hyperpigmentation. There is periorbital darkening, and people come for periorbital darkening, and many times people miss the fact that it is a metabolic thing which is happening, and it's not just simple periorbital pigmentation. Another case, and always these things are associated with acanthosis nigricans of the neck. There is also perioral darkening. There is accentuation of darkening all over the nasi, the sulcus nasi, and the mentolabial fold. There can be pediatric involvement, and there can be a combination of all this horizontal band, periorbital pigmentation with facial obesity. So facial obesity is something that you always want to check, because this is what a term we coined about 8 years ago, that these people have fat, not just on the abdomen, but also on the face. And that's why I'm calling it facial obesity. Acanthosis nigricans of other sites, associated conditions. For example, this lady has polycystic ovarian disease. Acrocordons. And this is what facial obesity, I meant by facial obesity. Look at this pear-shaped face. There is a scoring system. How much time do I have?
Still have 10 minutes.
Okay. So,
Timer on the right.
right, thank you, yeah. So now, coming to dermoscopy, this is a good tool to have instead of trying to cut up somebody on the face. You check both in non-polarized as well as polarized mode. And you'll see, I'm going to show you again pictures instead of talking about this in words. And milder facial acanthosis nigricans has these features in the third bullet, whereas advanced ones have the very, very prominent cristae and sulci, which again I'll show you in the dermoscopy pictures. There is also, you can take a picture of this because it's the color with the intensity of pigmentation, and there is a dermoscopic histopathologic correlation, which very beautifully tells us how to correlate these two. So this is mild. This is what we would call very mild lateral cheek involvement. And look at this. So the blue one is the blue arrow is with the papillomatous surface with accentuated skin markings, and the orange one is the perifollicular hyperpigmentation that you can very well appreciate. And then the slightly more severe, and that is again you'll see. Look at the various other benign skin changes, including solar comedones, etc. You can see that the facial pigmentation is much more intense. And here you see the very prominent sulci and gyri. So with the polarized mode, you can see this, which is an absolute telltale sign. Now, remember that this is a multifactorial disease, and therefore, there are many things which look like acanthosis nigricans, and you have to be very aware of that fact. So this is frictional melanosis, and this is a lot of people in the Indian subcontinent, they tend to rub their face. It also leads to post-inflammatory hyperpigmentation, and this is what it looks like. So it can be somebody with facial acanthosis nigricans rubbing himself or herself thinking that this is dirt, and which is actually worsening it. This is pigmented contact dermatitis, which is like something that you do with a low-grade allergen over a period of time, and this becomes dark. So this is something which can again look like fan, but then it's not fan. There is exogenous ochronosis. My previous colleague and co-chair talked about the Kligman formula. In the Indian settings, we have the modified Kligman formula, which does not have clobetasol, thankfully, but it does have mometasone with hydroquinone and with a retinoid. So you can imagine what happens. There is thinning of the skin, there is accentuation of this, and there is, of course, the exogenous ochronosis. Lichen planus pigmentosus, but remember that one of the differences in this is that they do not necessarily have facial obesity, because this is all because of other reasons. So it's not that there is accompanying hyperinsulinism. And then there is this maturational hyperpigmentation, which is a very typical American phrase, a term, which was introduced on the basis of one poster that was presented in a Johnson & Johnson sponsored study, a poster, and on African American people, and they found this. And this is slightly different because they said that it was happening only in one side of the face, where there was friction, where they were sleeping. They had diabetes. They did not have hyperinsulinism without diabetes. So the papers that we have described, they have hyperinsulinism without overt diabetes. So basically, if you do histopathological studies, you will see that it does not have something which is very uniform. So don't depend. There is no clear-cut diagnosis of facial acanthosis nigricans just based on the microscopic findings. And like I said, it's a multifactorial thing. There is rubbing, there is photo damage in countries like ours where there is all the time the sun, there is sunlight, there is exposure to chemicals, so there is local inflammation which heals with hyperpigmentation. Now, whether these are, initiating triggers in people who are predisposed or as a secondary additional effect is something that is waiting to be answered. Now, metabolic associations. This is something that, again, please do take a photograph of this, that there is almost always anything between 50 to 100% of people with FAN, they are obese, they are either overweight or obese, and they have a high waist to hip ratio. They have associated hypertension, which is in about 25 to 50% of individuals. There is hyperglycemia. They have elevated fasting sugar, and that is also pretty high, but not over diabetes. Hypertriglyceridemia is another thing that presents. Low HDL, again in about half of the patients that we see, and insulin resistance is the key marker. Now, how do you see insulin resistance? It is basically HOMA-IR. So the homeostatic model of insulin resistance, it's an assessment which is done. I'll show you the the, the formula also. But what do you do? You get a lipid profile, you check the sugars, you do HbA1c levels, you do the liver enzymes, because many of them, because of their obesity, have fatty liver, do the TSH, and if possible, get the HOMA-IR done. Please. How to calculate? So please take a photo of this, because this is something that is a research thing. We don't normally do it, because everything else points to the condition of facial acanthosis nigricans. You basically multiply the fasting insulin with fasting glucose, and then you divide it with 405 or with 22.5, and depending on the concentration. Yeah, so you'll know what it is, because the lab will give you a clear-cut report of whether there is hyperinsulinemia or not. Now coming to the treatment. Unfortunately, it is a very, very frustrating disease. Condition, I won't call it a disease. Dr. Ghate will definitely agree. I have a very well-known Indian colleague here sitting in the second row, and he will, I'm sure, agree, and many of the others who have seen this and have tried to treat will agree that it's really the most important thing to do is to lose weight. Weight reduction is the most important thing. And I mean, look who's talking, I'm sorry, but I also have fair bit of truncal obesity, but then that is something that has to change. People make the mistake of trying to show heroism by losing weight very quickly. And these are invariably the people who lose weight quickly, and they also gain that equally quicker, in fact, quicker than how they lost it. So I usually have the Varma's rule of 12, 1 dozen, that 1 kilo a month for 12 months. You tell the patient you lose 12, in 12 months you lose 12 kilos if you are diligent and if you are patient. And that can make a lot of difference clinically. There are chemical peels which are tried. There are systemic, there are oral retinoids which are tried. There are insulin sensitizers like metformin. I don't do lasers, but there are lasers which have also been tried, and I really have not met anybody so far in the past 10 years of working on this where something has really objectively helped. And there are all other things as well. With this, I will thank you for your attention. I'm from India, as I said. We have the Indian Association of Dermatology, Venereology, and Leprology, which is a 17,500 strong, member-strong association. And we have annual conferences usually in January and February, and I do welcome you to attend one of them, because I'm sure it will be a worthwhile experience for everybody to see all the skin type ranges from 3 to 6. Thank you very much. Namaste.
Thank you very much. It was a very interesting presentation, and I let you introduce Professor Paus. Shyam, you want me to say a word?
Okay, so Professor Paus is originally from Münster in Germany, and is now active in Miami, Florida, and he's basically a serious dermatology researcher. So with that, please.
Thank you very much. Good afternoon, everyone. So when dermatologists think about thyroid hormones, they usually view them as a problem. Too much, too little of them gives you hair loss, lots of other skin problems. But as dermatologists, we don't really think about them as a potential therapy, and particularly not as a potential topical therapy for hair loss. And I just want to share with you some very, very preliminary data we have on this, all on the level of preclinical research in organ-cultured skin. But let me think what let me hear what you think about this. So what you all know is that if you just have a little bit too much or a little bit too low serum thyroid hormone levels, you can get quite severe hair loss, particularly telogen effluvium, brittle hair shafts, and so on and so forth. Both too much and too little. And then many years ago, we just wanted to know, is this a direct or an indirect effect? And so we micro-dissected scalp hair follicles, threw them in a culture medium without any thyroid hormones in there, and dumped some thyroid hormones in there. So how does the follicle respond? And it was quite clear that it prolonged, that thyroid hormones, both T3 and T4, prolonged the growth phase of the hair cycle. They even stimulated pigmentation, keratinocyte proliferation, mitochondrial function was upregulated, and even the hair follicle cells responded in a positive manner. But if you think about thyroid hormones, you also have to think about the hormones that control thyroid hormone production, namely thyrotropin-releasing hormone in the hypothalamus and TSH in the pituitary gland. And since about 20 years ago, we had discovered that as you are sitting there right now, you're making in your scalp hair follicles all the hormones, the neurohormones that Selim talked about in his earlier talk. Later, more recently, we found that your hair follicles also make growth hormone and even the neurohormones that control growth hormone production. And these days, we're very busy trying to figure out, do your hair follicles even have something like a peripheral equivalent of the hypothalamic pituitary thyroid axis? But that is not what I want to talk about today. Today, I want to just ask the key question, whether topically applied thyroid hormones and topically applied thyrotropin-releasing hormone have any impact on hair growth in scalp skin. And for that, we use a very simple model, organ-cultured scalp skin, and we culture it for about 6 days. After 1 day of pre-incubation, so that the skin can settle in a thyroid hormone-free medium, serum-free, and then we topically apply every other day in a very simple vehicle the thyroid hormone. And the vehicle we used in this case was actually extremely simple. So ethanol in there and a large amount of propylene glycol. You would never use such a high percentage of propylene glycol long-term on human skin, but we just wanted to be sure to make that the hormone was making it to the skin. So we are really looking for an effect. And we got the skin from facelift surgery. And then what we saw, and these are the very first pilot data that we just published. It's a very small study, just in 3 donors, that indeed the hair follicles stay longer in the growth phase. It doesn't look very impressive, the increased percentage of anagen hair follicles here. But if you consider that this only happened within 5 days, and if you then would administer these hormones on the scalp for weeks in a row, you would get a much more dramatic effect. And even pigmentation was in some fragments a little bit stimulated, but in the majority not. But there was a slight stimulation of proliferation in the hair matrix if you compare these 2 slides. What really interested us, though, is that FGF7 expression. That's keratinocyte growth factor, one of the best-known hair growth promoting growth factors that the follicle makes itself, primarily in its outer root sheath. That was increased by topical application of triiodothyronine. And quite significantly so, at least in these 3 patients we looked at. So if you compare here the outer root sheath of the vehicle treated and the test skin. And even endothelial cells in this organ culture skin responded a little bit at least. They the number of CD31 positive endothelial cells increased. That's not evidence yet that there's real angiogenesis. Remember, these skin fragments are no longer perfused, and this has to be repeated, of course, in more than 3 donors to see this. But that would be quite exciting if thyroid hormones could indeed stimulate a blood vessel supply to the hair follicle after topical application. And what we also found is, and that was perhaps the most interesting finding, when we topically applied these thyroid hormones, then even the hair follicle epithelial stem cells in the bulge responded. And you look at this by measuring the amount of keratin 15, the stem cell associated keratin, and that went up. So these are, of course, very preliminary pilot data, and they leave, as usual, more open questions than they give us answers. First of all, we really need to know how reproducible is it if we look at more scalp skin samples in larger cohorts. Are there sex differences? So I think we had 1 donor was male, 2 donors were female. Then does any of this translate to the in vivo situation? Remember, our organ culture medium in which we grow, these skins are without any thyroid hormones, so this is a severely hypothyroid condition. So we basically make our skin artificially more sensitive to thyroid hormones. But this way you control the system best. Then, of course, we want to have a gentler vehicle than one with 50% propylene glycol in there. And this quite substantial upregulation of this key hair growth promoting growth factor, FGF7 or KGF, is there just a correlation, or is the effect that we saw on hair shaft production, is that actually dependent on this growth factor? That you can test quite easily by just putting a neutralizing antibody into the organ culture medium and see whether you still get the same effects. And is there real angiogenesis after topical application of thyroid hormone? That would be really exciting if we could show that. And if we can show that, then of course the next question is, yeah, and who is controlling that? And it's already known, we showed that in other studies, that thyroid hormone can indeed stimulate VEGF-A, so the key angiogenesis promoting growth factor. But there's a caveat. The stimulation of epithelial stem cells that we saw in the bulge, on face value, seems like a wonderful idea. Stimulating stem cells sounds good. But if we stimulate them too much and too many of these stem cells differentiate and become normal hair follicle keratinocytes, then we might exhaust the stem cell niche. So we could be shooting ourselves in the foot. So there we need long-term studies. And that you can easily do. You just take a piece of human scalp skin and you transplant it on a mouse that cannot reject it. And then you can study it for an entire year, for the entire lifetime of the mouse, and then you can absolutely certainly say, is there a long-term damaging effect on stem cells or not? But you don't want to exhaust the bulge stem cell pool. And long-term toxicity, of course, if you administer thyroid hormones over a large area of well-perfused scalp skin, you've got to expect that there might be some hyperthyroidism. That's not a big problem. You just stop doing it. And you can easily test it in the serum. But what we would think is that it's actually wisest to only do pulse therapies. Now, but what about the boss of thyroid hormones, thyrotropin-releasing hormone? And the reason we were so interested in that not only did we discover some 15 years ago that your scalp hair follicles also make this neurohormone, thyrotropin-releasing hormone, but they also very profoundly and strongly respond to it. They stay longer in anagen, they make more of a hair shaft, they even get more pigmented. Yeah, I think yeah, that's actually what we just did. So many years later, we tested this hair growth response. How dependent is it really on the thyrotropin-releasing hormone receptor? And a simple way of doing it, you stimulate the hair follicles in the presence of you stimulate it with TRH, and then simultaneously give a silencing RNA that downregulates the amount of the receptor. And if you do that, the follicle really hates it. It goes into catagen, as you see here on the left-hand side. So that means your hair follicles always want to be stimulated with TRH. That's probably made in your hair follicles directly, because the serum levels of TRH are very low. So that actually made us even more convinced that TRH is really important for hair growth, for human hair growth. We're not talking about mice here. And we also found years ago that indeed TRH is a very strong stimulus for hair pigmentation. We are now studying what about gray hair follicles? Can they be repigmented? And my suspicion would be that if there are still a few surviving melanocytes in these gray hair follicles, the answer will be yes, but we still have to show that. But what about topical TRH? Again, systemically you don't want to give it because you would immediately get hyperthyroidism. So we used basically the same setup that we had used for T3 with a slightly different vehicle, but with similar components. And we only have done a single donor source. So these data are even more preliminary than what I showed you before. And we got quite nice promotion of hair shaft production, at least in these organ-cultured scalp skins from a single donor. Disappointingly, these 5 days of organ culture did not suffice to keep the follicle long enough, longer in anagen than in the control group. Yeah, and if you are a very optimistic person, you may say, yeah, but it's moving in the right direction. So if we keep going it, and if you could grow our scalp skin organ cultures longer than just these 5-6 days, then maybe we would have seen something. But so we went on to ask, yeah, but what about proliferation in the hair matrix, and what about hair bulb pigmentation? What about all these key growth factors that we always look at in hair research? FGF5 FGF7 you already heard about. TGF-beta 2 we always look at. That's the key hair growth inhibitory growth factor, and IGF-1 is the key hair growth stimulatory one. And of course we looked again at the stem cells. And in this single donor that we so far have looked at, topical application of this very small neurohormone, it's a tripeptide hormone, 3 amino acids, actually stimulated some proliferation in the hair matrix. So if you compare this and this image, that tells you a few things. So that tells you that even though this is just a small peptide that we topically applied in this vehicle, deep down in the skin, in the subcutis, the hair follicle responded. So the vehicle actually is getting that peptide into the hair follicle without getting degraded. And it also beautifully corresponded to what we had previously seen in microdissected, isolated hair follicles, where we put the TRH in the culture medium, basically imitating a systemic application. Yeah, there was a slight increase in pigmentation, and I bet you, so that, of course I selected here a very suggestive image, but overall the effect is not very dramatic. But if we probably would culture longer, we would get more of a pigmentation stimulation. Then we looked at TGF-beta 2, and that was quite fascinating. So there was a marked reduction of this hair growth inhibitory growth factor. That's the key growth factor that pushes your hair follicles from anagen into catagen. And IGF-1 also went up, so the opposite, the key anagen prolonging growth factor, went up. That's exactly what you want to see. But those of you who are not asleep yet will have noticed that different concentrations of TRH had different effects. And that we still, we don't even worry about figuring out why that is until we have done several donors and then we see how reproducible is this. But it appears that different topical TRH concentrations will also give you different functional effects. And finally, what about these stem cells in the bulge, the key stem cell area of your hair follicles when you topically apply TRH in fairly high doses to a living human scalp? Skin in organ culture. And they, indeed, the number of these stem cells goes up, they proliferate a little bit, the overall expression of this stem cell-associated keratin goes up, and their death in culture appears to be reduced. Now, that is very interesting in the androgenetic alopecia field, because not only do your hair follicles stay not as long in anagen as they should, that gives you telogen effluvium associated with androgenetic alopecia, but they also get miniaturized. There, it's still not really entirely clear who is in control of that. Is that the derma papilla of the hair follicle doesn't secrete enough growth factors anymore? Or are the stem cells not producing enough daughter cells? And probably a mixture of both. So if you have a neurohormone that you can topically apply in your hand that actually stimulates daughter cell production from stem cells in your hair follicle, that should be a good thing, if you don't exhaust the stem cell niche. That's the caveat here, right? So all that is pretty exciting and at least encouraging in terms of that now we shouldn't only think about thyroid hormones as a problem. We should view them as a new therapeutic tool. Now, all of what I've shown you was not done on patients, but with patients' scalp skin in an incubator. That's still very far removed from real life, but at least I think we are so much closer to the clinical reality than any cell culture or mouse study possibly could be. So consider topical T3. And I would prefer T3 over T4 because the skin has the deiodinases that are needed to activate, to metabolize T4 into T3, but it's very unpredictable how good it does it. So some of us have a lot of this deiodinases, others have little. So I would rather go for the final product, T3, immediately. And the question also is, now that both of them have this hair growth promoting effects on different levels, is a combination of them actually what we really should do, because that might give us even better effects. And since we know that both thyroid hormones and TRH have an impact on aging in cells in mice, in cell cultures, and we had already shown that TRH and T3 both have anti-aging properties in human scalp hair follicles, microdissected organ culture. Of course, we now would like to know what else these topically applied thyroid hormones and TR3 doing to the hair follicle that might be beneficial for the hair follicle. But the other big thing, and that's what we are not talking about today, is what does the hair follicle even do with all these neurohormones? Why does it make them? I always say long before there was a hypothalamus and long before there was any neuroendocrine gland, there was the skin. In evolution, skin is the oldest organ and the largest. Probably the skin invented all these neurohormones. And then the other organs said, that's actually a good idea, let's use that too. But we still need to figure out what are these neurohormones doing, what's their full spectrum of physiological functions, because they are made in the hair follicle. And of course, you can go on and then ask, is this neuroendocrine, hypothalamic pituitary thyroid axis defective in hair loss disorders? Nobody has looked at this carefully. But remember the caveats. So on the one hand, you don't want to exhaust the stem cell niche, and you don't want to administer this too long to avoid hypothyroidism. Therefore, I would think if you want to treat telogen effluvium, you want to use a pulsatile treatment. A couple of days, maybe a couple of weeks, max, and then you stop, wait for a couple of weeks, and then you do it again. With this, I thank you for your kind attention, and the people that actually generated these exciting data, Jennifer Gherardini, Kinga Linowiecka, Jeremy Chiré, and a number of other lab members and the funders that supported this work. Thank you.
Stay here. Thank you very much, Ralph. For the, stay on the floor, Ralph. Yeah, with us, because for your future question, it was fascinating. Thank you very much, Ralph. And it's my pleasure now to introduce our last but not least speaker, who is Professor Émilie Spidian. Professor Émilie Spidian is a full professor in the Department of Dermatology of the University Hospital Henri Mondor, close to here in Paris. And I had the chance to know her when she was still resident, and she had done a great trajectory. And now she is an internationally renowned researcher in epidemiology, in psoriasis, in obesity. A number of studies are ranking in the highest journal, and I'm very happy to hear a summary of what she will tell us about her work on obesity and the skin that she will now target, and this is a very hot topic. Thank you, Émilie.
Thank you very much for the introduction, and good afternoon, everyone. So yes, we will discuss obesity and the skin, which is a large topic. So we'll start with skin and physiology changes in obesity that predispose to specific skin manifestations. We'll have a focus on skin inflammatory diseases in case of obesity, and quickly discuss skin side effects of anti-obesity drugs. So let me begin by a few key facts. And according to the WHO, in 2022, 1 in 8 people worldwide were living with obesity. Since 1990, the prevalence of obesity in the adult population has doubled, and for adolescents, it has quadrupled. And to date, more than 50% of the population live with obesity, and for children and adolescents, close to 200 million live with obesity. So this number emphasizes the fact that obesity is no longer an individual problem, but a global health epidemic with systemic implication. So obesity, beyond metabolic or cardiovascular implications, obesity will impact the skin. And the skin of an obese patient is characterized by increased subcutaneous fat, larger skin folds, and higher surface roughness. Obesity will alters skin anatomy and physiology through mechanical, hormonal, metabolic, inflammatory pathway that predispose to various skin manifestations. And it has been well shown that skin barrier, collagen remodeling, sebaceous gland activity, sweat gland function, and circulatory and lymphatic pathway are all affected. More recently, some authors have have demonstrated an association between skin microbiome and obesity or the weight. And regarding this study, including more than 100 gut oral skin samples, the author have demonstrated that both gut and skin microbial diversity were affected by body mass index. And for example, beta diversity as well as variation in microbial communities across individuals correlate with body mass index, especially the abundance of Corynebacterium species is associated with an overweight or obesity. And so this altered microbiota balance leads to cutaneous inflammation and provide a higher risk to develop skin infections or skin inflammatory disorders that are observed in the obese population. So let's move from physiology to clinical manifestations, and we already discussed them during the previous presentations. And we know that collagen remodeling is impaired and decrease the skin strength, leading to stria distantiae, described already by Professor Selim Arangtaji in this talk. We also know that obesity will alter microvascular pathway and create venous insufficiency with other skin characteristics such as varices, lower limb edema, legs ulcer, and lymphedema. And lastly, in this slide, plantar keratoderma is really a common feature of skin changes due to obesity, due to the excess weight will alter the foot anatomy. Insulin resistance is also common in the obese population, and there are some specific skin changes well described by Professor Wehrmann, such as acanthosis nigricans in the skin folds, fibroma pendulum, that are skin color papule in the same skin folds, or keratosis pilaris. And hirsutisms, acne, androgenic alopecia, or seborrhea are also skin manifestation of hyperandrogenism, which characterize patients with obesity. So obesity predisposes also to infection, including skin infections, and we've just talked about circulatory and lymphatic changes that predispose to a higher risk of cellulitis and erythema. Excess sweating and deeper skin folds create also a moist environment and some skin changes too, with intertrigo, which are macerate erythematous plaques developing within skin folds, and this intertrigo often complicated with infectious such as fungal, Candida albicans, dermatophyte, or bacterial. And erythrasma is also common in the obese population with and it is characterized by superficial localized skin infection, and this is caused by Corynebacterium. Obesity is also associated to the occurrence or the aggravation of some rare skin conditions, such as adiposis dolorosa in the left side, characterized by multiple painful fatty lipomas. It is also associated with obesity-associated lymphodemus mucinosi, which mimics pretibial myxedema without thyroid impairment, and lastly is more frequent with lipedema, which is an increased deposition of subcutaneous fat that presents with swelling and enlargement of the lower limbs. Lastly, obesity will impact the course of chronic inflammatory skin conditions. The most frequent are listed in this slide, with psoriasis, hidradenitis suppurativa, rosacea, or atopic dermatitis. And in the obese population, we have a higher prevalence or incidence of such disease, a higher severity, and obesity will influence also treatment response. And so let's take psoriasis as a well-documented example. In this study, this is a systematic review and meta-analysis, including 16 observational studies from 1980 to 2012, including more than 2 million study participants, among them 200,000 psoriasis patients. And the pooled result highlight that patients with psoriasis were 1.7 more likely to have to live with obesity compared with those without psoriasis. So psoriasis patients have a higher prevalence and incidence of obesity. The second study is really interesting because the author used a smart approach called Mendelian randomization approach, allowing to infer causal inference between obesity and psoriasis. And they confirm a causal link for obesity and the risk of psoriasis. So patients living with obesity is at higher risk of the onset of psoriasis during his life. Regarding the association, another interesting thing is a dose-response manner between the two characteristics, and patients with psoriasis, so at a higher risk to present obesity, but this association varying in a dose-response manner, and the association is stronger with severe psoriasis. So what happens when people lose weight? And using this result from 14 observational studies, including 150 patients, we have some data before and after bariatric surgery. So the average baseline of body mass index was 44 before bariatric surgery, and the population was divided in terms of severity of psoriasis, in 10% with severe psoriasis, and the majority, 75%, who had a moderate psoriasis. So what happened after bariatric surgery? Of course, the average BMI decreased to 33. And the majority of psoriasis patients saw their severity, an improvement of their severity. They were mild or completely resolved with their psoriasis. Most patients continue psoriasis treatment following the surgery. However, many experience a significant downgrade in medication category. So really interesting results. Lastly, obesity will influence therapeutic efficacy in this population. And in this Spanish study, the author demonstrated that patients with a higher BMI have a higher risk of drug discontinuation. So loss of efficacy has been shown for TNF inhibitors, but also for other biologics, ustekinumab or anti-IL-23 inhibitors. Obesity will also increase the risk of drug toxicity, and so methotrexate, hepatotoxicity, acid-rating-related metabolic syndrome or cyclosporine-related nephrotoxicity are all common in the obese population. So altogether, obesity patients will have a lower efficacy of drug for skin inflammatory disease, a higher risk of toxicity of the drug, and obesity will accelerate drug discontinuations. So in daily practice, we have to take into account the weight of the patient, and we could optimize maintenance dosage. As example, rather than use 40 milligrams every other week for adalimumab, we could increase the dosage at 40 milligrams every week. And you can see that there are several examples to optimize this maintenance dosage. And so we need to think about that for overweight and obese patients. A last thing regarding psoriasis is this really recent study from the UK researcher that developed and validate a nice tool dedicated to personalized dosing interval. So they use as gold standard pharmacokinetic measures from phase 3 risankizumab trials, and using simple characteristics of patients such as body weight, serum albumin, serum creatinine, and severity of PASI. They developed this tool, and so according to your characteristic, you know your dosing interval. And so, of course, we need to extrapolate this result to the other biologics and in other also conditions such as non-response, but it is a good tool to reach precision medicine. So for other diseases, it's the same thing. Hidradenitis suppurativa, higher risk of living with obesity, higher risk of severity, higher severity of the disease, and higher risk of treatment failure in this population, and improvement of outcome after bariatric surgery. So let's move now to adverse skin reaction to anti-obesity treatment. So the treatments are listed in this column, and so you can see that obesity treatment include analog of GLP-1, orlistat, naltrexone, and tirzepatide. And all these drugs have been reported to create some skin side effects. The skin side effects are very various, from mild to severe skin side effects. So it is important to know that this is possible, and this is the reverse side of story. In the same way, we've just shown that bariatric surgery could improve outcomes for chronic skin diseases, but it could lead also to skin side effects such as alopecia, bowel-associated dermatosis arthritis syndrome, both related to nutritional deficiencies. So to conclude, obesity alters skin anatomy and physiology changes, and these changes concern both skin barrier, collagen remodeling, sweat and sebaceous gland functions, and circulation pathway. And these changes leads to skin manifestations that are also various and not specific to obesity, but specific to the consequence of the obesity, and include plantar keratoderma, stria distantiae, skin infection, hyperandrogenism, and insulinoresistance manifestations. We've seen also the higher risk of chronic inflammatory skin disorder in the obese population, its higher severity, and a decreased response to systemic treatment. And so we need to adapt the doses of the treatment in daily practice, and we need to take into account the weight of patients in a holistic approach of dermatological care. Thank you very much for your attention.
Thank you very much, Professor Spidian, for this very clear, very precise presentation. Very interesting. I propose that you sit down here, and we have time, like we have precisely 10 or 12 minutes of time for discussion. If you want to ask questions, please come to the microphone and you can ask the question. In the meantime, while people will thought about the question, I can ask you a question, Professor Verma, concerning this interesting facial acanthosis nigricans that indeed once I saw that I have never seen, but when you saw the picture, I have seen of them. Are there cases in which this acanthosis nigricans is really limited to the face, and you have only the face that is concerned, but you have nothing on the other folds, but only the facial involvement?
That's a good question. This is one of the things that we have never seen. And there are people who have asked this question before. Okay. That do you see only facial acanthosis nigricans without involvement of involvement of the skin elsewhere, without any AN elsewhere on the body? The answer is no.
Okay. Thank you very much. And maybe again if nobody, I can ask, you want to ask a question, or? Yeah, no?
No, I wanted to comment on your, your talk, especially for somebody who's from France. And you were talking about fungal infections.
Yes.
And this is so very common when people are applying potent topical steroids for other conditions, not just bullous pemphigoid that you mentioned, but so many other conditions. And this particular species, the Trichophyton indotinei, which has also come to France, for example. It's come to Europe. I mean, the maximum number of cases are probably in Germany. We've been working a lot on this. And this definitely is one of the major reasons for causing fungal infections.
Which disease you said? Sorry, I didn't catch.
You said bullous pemphigoid.
Yeah.
You said you apply bullous pemphigoid.
I said that we give in France a lot
of course.
Yeah.
Of course, but you know, especially in developing countries, they have these combination creams, and
yes.
yeah, and most of them contain clobetasol. They also have an aminoglycoside like gentamicin or neomycin, and they have an antibacterial. So it's like 3 drugs put into one, and they're freely available over the counter, though there are rules. And this is what actually is one of the drivers of Trichophyton indotinei infections, which is now becoming a global threat. It's a public health threat.
Well, it's a very interesting remark. I see patients of mine who also come from international countries, developing countries, and they have de novo this triple association. And indeed, in France, initially, when I was a resident and even a chief resident, this existed. And then the agencies have stopped this to try to drive more precision diagnosis and not to mix them always. So it's interesting to see that there are still large parts of the area where they use it, and it drives fungal resistance. This is what you are saying.
Oh yes, because Trichophyton indotinei is known to be antifungal resistant disease, and then you have this. So it's an iatrogenic effect.
You want to comment, Ralph, or Emily? No, it's okay. It's really interesting. What do you give when you have this type of trichophyton? You have to give an oral treatment with terbinafine?
Now, the problem is that there is the most frustrating part is terbinafine resistance.
Also terbinafine resistant?
No, it's primarily terbinafine resistance.
So you have to give...
It can be anything between 20 and 65% of Trichophyton indotinei are resistant to terbinafine. Right. So itraconazole is the way to go.
So that was a really wonderful lecture. Thank you very much. Since this is the dermato-endocrinology session, and I was wondering, you were complaining how frustrating the therapy is, facial AN. We all know that one of the most potent stimulators of epidermal pigmentation is alpha-melanocyte stimulating hormone, right? Via the melanocortin-1 receptor. So there is the agouti signaling protein that blocks signaling through this receptor very selectively. Can we use that topically?
With which?
Agouti signaling protein. Agouti is the melanocortin receptor antagonist, right?
Why don't you try it with us?
Wonderful idea. Here we go.
Let's do that.
Yeah.
And on that note, thanks for your comment. The semaglutide, for example, that you mentioned, semaglutide is I have seen personally, but not documented yet. There are patients with facial acanthosis nigricans. They go on semaglutide, and the pigmentation markedly decreases.
Yes, it's logical.
It's really interesting. Yeah.
They also get hair loss,
yes.
Right? Not all of them, but I actually discussed it with some pharma companies, and so they say, that's just because they lose so much weight so rapidly. But I don't think so. I think the hair follicle has receptors for GLP-1, and we just have overlooked this. So yet another hormonal facet of hair biology that we need to look at.
Still no question I can ask, because we have just 2-3 minutes. I can ask questions to Professor Bidian. Yesterday morning, I heard a lady from California, a colleague, talking about something I didn't know, but which is concerning the GLP-1 agonist, is besides the muscle loss, because they insisted there is a lot of muscle loss in patients who have this treatment, much more than with other types. but she talked about skin aging. And they said that because of this reduction, well, she showed photos. I didn't go into the series, so it's a naive question. She said that, of course, the patients are very happy because they lose the weight, the females, but they have a big skin aging. Did you know this, Emily?
Maybe the same mechanism compared with bariatric surgery too. So mechanical one, I think, or
no, I think we also get focal lipoatrophy. So there's in foci, particularly in your face, you're losing subcutaneous fat. And I've seen physicians who were very proud to get rid of their obesity problem, and well, they look 20 years older exactly. Afterwards, no? Have you seen that too?
Oh, yes, absolutely.
Well, here we go. Yeah. But we need to know the mechanism. Nobody even studies that mechanism properly.
It can be done by, because we have a lot of patients, eventually this can be addressed now.
Well, you know me, I would always do it in skin organ culture first, right? So first you take a piece of human skin, you torture that with whatever drug you want to administer, and then you see what the skin has to say about it.
Yeah, exactly. Are there other questions?